Hello, my name is Laura Ellerton and I'm a CT1 in anaesthetics. I'm about 6 months into my speciality training, but I've not had the smoothest in terms of career pathways. I was quite late coming to medicine as it was, because I had a few jobs before I came to medicine. I got pregnant whilst I was in my first year of college, which then made it a little bit rocky to then get into medicine in the first place. Once I got into medicine, it was pretty smooth sailing. Went through my degree and then did my foundation years 1 and 2. After that, I wasn't entirely sure which route I wanted to go through, whether it was the surgery or the anaesthetic side. I knew I was quite good with my hands and quite good in terms of decision making, so it had to really be one or the other. I applied to both and got into both, but deferred them because I still wasn't entirely sure which of the two I wanted to go for. So then I did a year of doing education fellow. My reason for this is I love teaching. When you start with in medical school, you realise that teaching isn't quite as easy as you think it is. And then when you become a foundation doctor, you spend so much time with medical students, you find out what works for you. And it's really fun when you sort of find out that they're interested in what you are. So I spent a whole year teaching medical students, and I thought, okay, fine, I'm going to have to make a bit of a decision now. So again, I applied to both anaesthetics and surgery because despite having a year, I still didn't know what I wanted to do. Again, I got into both and then I kind of had to make a decision. Between the two, I decided that I'd go for surgery. It's probably not the best of reasons, but for me, it was because I thought I could always go back to anaesthetics. I liked the way that anaesthetics saw what you had and what you learned from other specialties, and they saw that as a positive. Whereas surgery, with how intense the training is, they expect you to want to always do that, so they're not as interested in you doing other things beforehand. So I thought, okay, I'll do surgery. I then entered my core surgical training, where I did 2 years with an orthopaedic theme, which means I did some plastics and some general surgery, mostly orthopaedics. And I enjoyed it. It was really fun. I loved my cohort of patients. I loved my operations. I loved my teams. I loved the way it worked. But there was just that niggling thought that I wasn't as happy as I should be. And I was getting a little bit burnt out with the stress of trying to keep up with everything and home life. After completing core training, I spent a couple more years working in orthopaedics. And as I said, I absolutely loved orthopaedics. I loved the way that everything was run, but I still wasn't really as happy as I should have been. So then the pandemic hit and everything changed. All the hospitals changed the way that they worked. Most people in most surgical specialties ended up going back into medicine to try and help them out in whole hospital rotas. Every day you could be on a different speciality. I moved from stroke to non-invasive ventilation to cardiac rehab, in 1 week. And you get to pretty much try and root out everything that you learned in medical school and start again. And that was the point where I thought, actually, I'm just not in the right speciality. So I then took another year out, and went back to my first love of education, and I did a whole year of simulation training. So I taught not just medical students, but I taught ODPs, I taught nurses, I taught everyone. And then I applied to anaesthetics. And I was lucky because all that experience that I got through my foundation, through my education fellow, through my surgical training, through the pandemic, and through more simulation training, all helped me in terms of my interview and getting into anaesthetics. And it's made me the better doctor that I am today. So a little bit about my speciality. I'm only 6 months in, so I can't tell you everything. But at the moment, my job is split between elective and emergency work. For the first 3 months of anaesthetics, you're intensely trained one-on-one with a consultant. You're not on the on-call rota. They want to teach you how to do an appropriate pre-op assessment and to optimise your patient, how to be able to deliver a safe anaesthetic, and all the basic airway skills that you're going to need when you're on call. Once you've completed those first 3 months training and they're happy with your progression, you're then allowed onto the on-call rota. Once you're on the on-call rota, you do have normal days where you spend them with consultants, and that's normally your elective work. Patients have already seen by the pre-op, and you're just there to get them through their anaesthetic. Sounds very easy, it's not always easy, but in general, get them through their anaesthetic and then make sure that they're safe in recovery afterwards. When you're in emergencies, it's not as safe and smooth as that. It is safe, but not as smooth. You could be doing everything or doing nothing. It's feast or famine. You're on you are the first on anaesthetic, so you are therefore the first person that's called for a cardiac arrest, for a trauma call, or for a transportation of a patient. Currently, I'm in a small DGH, which means that we don't have all the services that some big teaching hospitals have. So any patients that require neurosurgery or an out-of-hours scope need to be transferred from our hospital to a hospital that provides those services. Same goes with burns. As the anaesthetist, if the patient is that unwell that they require intubation or just general support during their trip in the ambulance, my job is to support them during that. The other side of on-calls is the emergency theatre list. So anything that comes in that's unpredictable. And that's mainly general surgery here. And that's usually your appendixes, any laparotomies that you need. And sometimes you get a little bit of urology, such as a testicular torsion. And you can get some paediatric work in there as well. The thing to say is you're always wonderfully supported. There's always a named consultant that you can go to. And if you go and see a patient pre-op and you're a little bit worried in terms of anaesthetic or you think you're going to need an extra pair of hands, the consultant will be there the entire time. If you think that you're okay with this patient, they'll be in the coffee room or somewhere out of the way, but close enough if you do happen to need them. So the benefits of anaesthetics, I'm only just starting to find them out. It's really nice when you turn up to a place and everyone's quite happy to see you. It's always a little bit sinister as well. But whether it's a cardiac arrest or even you just put in a cannula, and everyone's suddenly got these nice little smiley faces and they're all quite happy to see you and they'll bend over backwards for you, which is quite an unusual experience to go through. It's also still quite practical, which I like, so every day I get to learn a new thing and I'm not sitting behind a desk. But there's also loads of things you have to think about, so you have to go back to your bare basics in terms of your medicine, because keeping somebody stable and well throughout the whole of an operation when essentially the surgeon is creating an insult into the physiology of the patient is not always straightforward. As I progressed through my career, and when you get to being a consultant, there's some really good benefits to anaesthetics. It's quite modular in terms of career plans. So one session is a half a day in terms of surgery, or half a day in pre-op, or half a day or wherever you happen to be. So when you're doing your consultant plan, you get so many sessions that you do, and with them you can populate them in whichever areas you want to be, whether that's obviously within the hospital parameters and what they need. Is you can spend some time in maternity, you can spend some time on ICU if you're dual accredited, you can spend some time in theatres. You can use some of your modules to help out in terms of the academic side, and you can help out with teaching. It's really, really flexible. And if you happen to want to be less than full-time, that's absolutely fine as well. With the way that the modular system's worked, it's not that you have a patient for a really long time that you have to look after, that you're at home constantly worrying what's going on if you're a less than full-time person, because you have your patient, you see them, and then they're going to wherever they happen to be going afterwards. The drawbacks to this career plan, I mean, in terms of path for me, I've been round the houses, so mine's taken a really long time to get to where I want to go. I don't think I would change it, because I think there's so many skills that I learned along the way that's got me here. But in terms of where I am at the moment, the core anaesthetics gets you through is it's very linear, and it gets you the bare basics of anaesthetics. If you want to do your pre-hospital medicine, where you get the fun things like transporting people in a helicopter, or go out into this major trauma, or whatever it happens to be, that requires extra time. And that usually requires you going back and spending some time in A&E as an SHO. Same goes for if you want to do ICU. That's a bit more time that you have to spend. If you go through the ACCS instead of core anaesthetics, that does give you quite a big bulk of it, so you might not have to go backwards after that. But you do need to be dual accredited for it. As it is, it does get you through to being just an anaesthetist. Not that ever just an anaesthetist, but it gets you there. From then on, like many specialties that I didn't realise as a medical student, and I don't think I realised as a foundation either, but going through the training programme isn't enough. So particularly when it comes down to surgery or when it comes down to anaesthetics, you're expected to do certain fellowships afterwards in an area that's really interesting to you, whether that be paediatrics, whether that be maternity, or whatever you want as your extra skills to bring to your team when you go to your hospital as a consultant. So again, that's going to take a little bit of extra time. The requirements for the role. In terms of personality traits, you've got to be able to hold your facial expression and fake it a little bit. When everything goes badly, where everybody is going to look is to the anaesthetist. As the anaesthetist, you have to remain calm and exude this calmness amongst the team, because as soon as the anaesthetist looks stressed, everybody comes stressed, and then it suddenly becomes a far worse situation than it is. So no matter how bad it is, you've got to look cool, calm and collected, even if that's just for the patient. You've got to be good with your hands, both hands, because a lot of things you'll be doing one thing with one hand, another with the other, and then your eyes are somewhere else. So you've got to keep those hands going. You've got to have some good bare basics, and I'm afraid that includes physics. One of the things that I'm learning a lot about now is all the physics that's come down to a anaesthetic machine. All that time in A-level physics, you'd never thought you had to need it. Suddenly I'm having to learn everything all over again. So yeah, you've got to be able to go back over all of those basics that you had. Above all, what I think people are looking for when I went through the interview is someone who they thought could be part of their team. As an anaesthetist, you have to, obviously, as I've said before, be the leader because everyone's going to look at you. But you also got to work in a team. And when they're interviewing you, and what the whole of speciality training is, no matter what specialty you go into, it's a really long interview when you get into it. So this is just, you are doing years going around different hospitals, and you're essentially interviewing for the job that you will get when you come out of it. And the interview to get into the speciality training is just the first hurdle. And they're looking for somebody that they think will be good and work well and fit within their team. So you've got to be able to talk to your patients a little bit and relax them, because as much as everyone thinks that people are scared of surgery, they're not. They're scared of going to sleep. So you've got to be able to talk to your patient, you've got to be able to communicate with your team, and you've got to be able to communicate whether that's on the phone or whether that's language line or whether that's in the room that you are. How to apply for this specialty. As I've alluded to before, once you've done your foundation training, you're then eligible to apply to anything from then on in terms of speciality training. There is a few catches and providers there. So for example, if you're not trained in the UK and you haven't been through the foundation training, but you are currently in the UK and you're spending some time here and you don't have an equivalent that Oriel is happy with, there is a form that you can fill in, and you just get your supervisor to go through, and there's just certain different questions to make sure you're of the standard of an F2. Also be aware, if you're not going to go through a straightforward sort of trajectory like I did, that foundation sort of training times out a little bit. So because I'd been around the houses, I had to fill in that form to say that I was the level of an F2 or above, just because it had been so long. So if you happen to have a family, become ill, or whatever happens after your foundation training and you've completed that, just check the timing on that, because you might have to go back through and fill in that form. There's also the MediRoots website and book, which is really good. It'll have all the entry requirements, because that changes every year. But in general, most of the specialities have very similar in terms of what they want from you. And they want you to take part in some audits if possible, do a little bit of research. If you're doing that at medical school, that's brilliant, that counts, don't worry. If you don't do any research, that also doesn't matter, because sometimes you've been through your medical school and there haven't been the opportunities to do research, and you come to, say, a DGH where there's no research going on. That's also okay. Just put a little bit more effort and do a few more audits, and you can usually get the points back up that way. If you have the time, try and do an extra postgraduate certificate, particularly in medical or clinical education, because that will always max out your points in terms of the education side. If you don't have the money, because let's face it, £4,000 is a lot of money to spend, but if you don't have the money or time, don't worry, you can still get your maximum amount provided you contact your medical education department really early, your postgrad, or even your undergrad, and you spend a lot of time and you're involved within it quite regularly. You can usually get nearly full max points in terms of your education side. So there's ways of working everything around, because everybody has a really different experience from medical school and they have a different experience of foundation training. So don't feel like you're down from wherever you've been, because you can always make up some points if you just have a look at the person specification. If I had to do it all over again, to be honest, hindsight's a wonderful thing, and I would like to say that I'd go straight into anaesthetics. I'd still do my education, don't get me wrong, I absolutely adored that. But I don't know if I would be as good an anaesthetist as I am now, and I don't know if I would be as strong in terms of my communication, my leadership, me as a whole person and as a whole doctor. You'll find your experiences make you. So as much as I'd say I'd love to just cut a few years out and go straight forward, I don't know if I would. Probably would shave off a few years along the surgical side, but other than that, I'm quite happy with how far I've gone. The one thing that I would say to people is, if you're a reasonable doctor and you're quite good friends with people who are in different specialties, they will always try and tell you that their specialty is amazing, unless they're having a really bad time. Some do. But they'll tell you that their specialty is great and that you will be great in that specialty. And the sad truth, well, not the sad truth, probably the great truth, is that most doctors could probably do most specialties. But it's about finding a specialty that you're happy with and that works for you. So I hope this has been useful, and I am once again going to meticulously plug the MediRoots. I've just had a little flick through, and actually it's really useful, and I wish I had something like that when I was applying to speciality training. So good luck, and don't worry if you don't have the straightest trajectory in terms of career path. Whatever happens, happens. There is no such thing as a wrong or a bad mistake in terms of your career path. It's just something that's happened, you learn from it, and you can move on to the next thing. And don't be afraid if you're in a specialty and you've gotten so far that you think, I'm really far into this now. You can always turn around and you can always start something else if you think that will make you happy.